Good day, dear students. Today lecture titled Acute Pancreatitis. By the end of this lecture, you have to be able to define the pancreatitis, know the etiology and causes of pancreatitis, the different types, pathophysiologically changes, the complications of pancreatitis, and the most common line of management as well as nursing intervention during the care of the patients with pancreatitis, and finally relate the corresponding pathophysiology to the nursing practice. Based on your previous anatomy and physiology background, as you know, pancreas has two main functions, either endocrine function as well as exocrine function. Endocrine means that the pancreas will secrete enzymes or hormone directly into bloodstream, while exocrine means that the pancreas will secrete some enzymes via pancreatic duct into gastrointestinal tract. Regarding to the exocrine function of the pancreas, which is responsible for secreting the hormones insulin, glucagon, somatostatin. Insulin secreted by islet of Langerhans beta cell, and glucagon by alpha cell, and finally somatostatin by delta cell. You have to remember that somatostatin inhibits the secretion of insulin and glucagon. Regarding the exocrine function, you have to remember that pancreas secretes an alkaline juice with enzymes. These enzymes include amylase, protease, and trypsin, as well as lipase. And you have to remember that amylase has a role in the digestion of carbohydrates, while trypsin and protease adds in the digestion of protein, and finally lipase has a role in the digestion of fat. Regarding to the definition of acute pancreatitis, which is defined as an inflammation of the pancreas. This inflammatory condition or inflammation mainly initiated by injury to acinar cell of the exocrine pancreas and mainly responsible for premature activation and premature release of damaging enzymes with excess release of pancreatic enzymes secretions. These enzymes subsequently responsible for release of inflammatory chemicals and inflammatory mediators. These inflammatory mediators were responsible for further destruction of within the pancreas itself, or what we call autodigestion, which means that the pancreas will digest itself as well as will affect the surrounding tissue and maybe the surrounding organs. That's why we mentioned previously in the lecture of multiple organ dysfunction syndrome that the acute pancreatitis is one of the triggering factors for this condition. Regarding the types of acute pancreatitis, which can be acute or chronic. Acute, which means it will begin suddenly and lasting few days, while the chronic conditions, which mean it will occur over many years. Regarding to the acute pancreatitis, which also classified into two main types. The first one will be the mild pancreatitis or interstitial, which mainly characterized by parenchymal interstitial inflammation as well as edema, which responsible for abdominal pain, severe abdominal pain from the patient's side, and higher level of amylase as well as lipase enzymes. On the other hand, severe acute pancreatitis or necrotizing pancreatitis, which mainly characterized by infection and parenchymal necrosis, and also there is a severe hemodynamic instability or compromised, as well as the patients will predispose to the development of multiple organ dysfunction syndrome, as we mentioned before, especially among the elderly patients due to the compromise of their physiological function of the organ. And regarding the severe acute pancreatitis, the patients should be admitted to ICU. Regarding to the causes of acute pancreatitis, biliary causes such as cholelithiasis or cholecystitis, as well as alcoholism, are the most common causes. Also, surgery involving the pancreas itself or near to the pancreas, such as endoscopic retrograde cholangiopancreatography, ERCP. Also, the metabolic cause such as hypertriglycemia, hypercalcemia, as well as renal failure. Infectious causes such as mumps, viral hepatitis, mycoplasma, candida, and TB. Some medications such as estrogen, corticosteroid, thiazide diuretics, furosemide diuretics, as well as sulfonamides medications, which all these factors may trigger or predispose to the development of acute pancreatitis due to direct toxic effect to the pancreas. Also, diuretic-induced stimulation of the pancreatic secretion, as well as ischemia. Regarding to the abdominal trauma, can predispose to acute pancreatitis, especially direct injury to the pancreas and pancreatic tumors. And finally, connective tissue disease such as vasculitis and lupus and thrombocytopenic purpura. As you see here, for the patients who developed acute pancreatitis, you can see that around 40% of these patients are due to heavy alcohol consumption, while another 40% of these cases due to gallbladder stone or cholelithiasis, and finally the 20% due to the other causes as we mentioned before. Regarding to the pathophysiology, as you see here in this algorithm, the triggering factors or etiological factors include the higher alcohol consumption, biliary tract disease such as cholelithiasis, trauma direct to the pancreas or nearby to the pancreas, and infection, and some drugs with the toxic effect to the pancreas, and post-operative gastrointestinal tract surgery, and the idiopathic causes or unknown causes. All these factors will trigger the activation of pancreatic enzymes with a higher level of all pancreatic enzyme secretion. Also leads to injury to the pancreatic cell, including the Eschenner cell of the pancreas. All the activation of pancreatic enzymes as well as this pancreatic cell injury will responsible for what we call auto-digestion to the pancreas, which will responsible for increasing the trypsin level, elastase level, phospholipase, as well as lipase. All trypsin will responsible for developing edema, tissue necrosis, and hemorrhage. Elastine will cause hemorrhage, and finally phospholipase and lipase are responsible for fat necrosis. Also, this image illustrates that here there is a destruction of the Eschenner cell of the pancreas due to the triggering factors or the causative factors responsible for acute pancreatitis. All these factors will responsible for increase the pancreatic enzyme secretion and responsible for leakage of the enzymes via the pancreatic duct. All these responsible for higher amylase level and lipase level, which predispose to the fat necrosis, and protease and trypsin, which are responsible for vascular destruction. All these factors will finally end with acute pancreatitis. Also, here in this algorithm, you will see that pancreatic activation will release the higher trypsin, lipase, amylase, higher pancreatic enzyme secretion, and we're responsible for autodigestion, as we mentioned before, and will increase the simulation cascade and activate the consequence effect were responsible for more fat necrosis to the pancreas, and all inflammatory mediators will be released into the patient's body. All these inflammatory mediators were responsible for developing of systemic inflammatory response. So the consequence effect of the acute pancreatitis will develop sears and shock, mainly hypovolemic shock due to massive vomiting from the patient's side, and the cardiac dysrhythmia, and the adult respiratory distress syndrome, and gastrointestinal tract bleeding, and acute tubular necrosis, and disseminated intravascular coagulopathy, and finally may predispose to encephalopathy. To sum up, what will happen in the patients after developing acute pancreatitis, the patients will develop premature enzyme activation of pancreatic enzyme secretion, which is responsible for what we call autodigestion of the pancreas, and this will trigger the inflammatory cascade for the patient's body, and consequently higher level of pancreatic enzyme secretion will alter the digestion of carbohydrates, fats, and the protein due to higher level of amylase, lipase, trypsin, and protease, and all these factors will be responsible for abdominal pain, impaired gas exchange for the patients due to systemic inflammatory response syndrome activation, and predisposed to hemodynamic instability, and predisposed to further complications for the patients. Regarding to the most common sign and symptom for the patients with acute pancreatitis, severe upper abdominal pain mainly radiates to the back of the patients due to cell necrosis, and diffuse abdominal tenderness, including girding or abdominal distension, in addition to nausea and vomiting without pain relief, hemodynamic involvement, including tachycardia, hypotension, and the hypovolemia due to massive vomiting from the patient's side, low-grade fever, increased white blood cells count, hypoactive bowel sound or absent of bowel sound, and may predispose to paralytic ileus. Basilar rales and pleural effusion may be developed due to the development of edema. And finally, the patients may develop jaundice in case of biliary disease. There is a two most common sign among the patients who develop acute pancreatitis include gray Turner's sign, which is described as flank ecchymosis or bruising, and this sign indicating that the patients developed pancreatic necrosis with retroperitoneal or intra-abdominal bleeding. So this ecchymosis or bruising indicating that there is an inner bleeding. And another sign, namely Coulin's sign, which is described as periumbilical ecchymosis or ecchymosis around the patient's umbilicus or umbilical area, and it occurs mainly in the presence of hemorrhagic pancreatitis. Also, you have to remember that the patients will develop higher amylase level and serum amylase level, and as well as urine amylase level. As we mentioned before, because acute pancreatitis can be ranges from mild to severe condition, so you have to predict the severity of acute pancreatitis using the Ranson criteria, which is used to assess the severity of acute pancreatitis, and it consists of a group of clinical criteria used to identify who is patients at risk for increase their morbidity and mortality. As you see here in this table, you can see the reference range of the score of Rensen based on these clinical criteria. If the patient score ranged from 0 to 2, the morbidity will be 2, or if the patient's risk score will be 3 up to 4, the morbidity rate will be 50%. And finally, if the score ranged from 7 up to 8, the patient's mortality rate will be 100%. As you see here, the clinical criteria for Rensen risk score for predicting the acuteness of patients who developed pancreatitis. These criteria will be assessed on admission, and you have to do again during the initial 48 hours from hospital admission. You have to remember all these criteria very well. And as you see, all these are clinical parameters, including how far the severeness of the patient's condition. Regarding to the laboratory investigations, which is important to confirm the diagnosis of acute pancreatitis, as you see here, you will find in this table that the patients will develop high serum amylase and lipase level, which is pancreatic enzymes, and mainly due to the release of the pancreatic enzymes into the blood through the pancreas. Also, you will see that the patients will develop higher blood glucose level, which mainly indicating the impairment of the insulin production and which is released by beta cell of isolate of Langerhans. Also, the patients may develop hypokalemia, low serum potassium level due to electrolyte imbalance secondary to massive patients vomiting, as well as hypokalemia because hypocalcemia, which mainly due to that the calcium always combined with fatty acid released during the fat necrosis stage of acute pancreatitis. Also, the patients will develop hypertriglycemia, which mainly due to acute inflammatory process. Also, the patients will develop a low albumin level or hypoalbuminemia due to shifting of the fluid into the extracellular space. Also, the patients will develop high bilirubin level, AST and PT, which may also secondary to the presence of liver disorders or liver disease. The patients also will develop a higher lactate dehydrogenase, secondary to the biliary disease or biliary disorders, such as cholelithiasis. Also, the patients will have a higher alkaline phosphate level in case of biliary disorders. And finally, the white blood cells count will be higher due to inflammatory process. Regarding to the medical management of the patients with acute pancreatitis, it mainly aim for providing an initial supportive care and provide preventive strategies, and finally surgical intervention or management of the patients. Regarding to the initial supportive care for the patients with acute pancreatitis, it will include aggressive fluid resuscitation, pain management, nutritional support, resting pancreas intervention, as well as further medical management. Regarding to the fluid resuscitations, the patients with acute pancreatitis will lose large volume of fluid, especially during the massive vomiting stage, or internal loss into the retroperitoneum or intra-abdominal area. That's why the patients will need intravenous fluid resuscitation, especially during the first 24 hours during the acute phase. As we mentioned before, the fluid resuscitation will include both colloid as well as crystalloid, starting first with crystalloid, then colloid, and the infusion rate usually of the rate of 200 up to 250 up to 500 milli per hour. And you have to remember that the patients with acute hemorrhagic pancreatitis may also need packed RPCs to replace fluid. That's why you have to monitor the patient's fluid volume status through measuring the patient's central venous pressure, measuring pulmonary artery wedge pressure, and measure the patient's urinary output. And as you know, the patient's urinary output must be ranged between 30 up to 50 milli per hour. This is considered as an indicator for adequate hydration status. And you have to remember that your patients at risk to develop either hypovolemia or hypervolemia. That's why you have to carefully document the intake and the output for your patients. Furthermore, you have to monitor your patient's serum electrolyte level, especially potassium, calcium, and sodium. Regarding to the patient's pain management, you have to be aware that pain control is one of the first line of management for the patients with acute pancreatitis, because excessive pain and discomfort will stimulate further pancreatic enzyme secretions. So you have to control the pain to control the higher pancreatic enzyme secretion level. That's why you have to start pain medications in the form of intravenous narcotics, or use patients controlled analgesia, which is an essential for the management of the patients with acute pancreatitis. Also, you have to remember that analgesia should be routinely administered at least every 3 to 4 hours to prevent uncontrolled abdominal pain. Also, positioning your patients for comfort, and you have to be alert that narcotics may predispose to the development of respiratory distress, or the depression of the respiratory center. So you have to monitor your patient's respiratory rate frequently. Regarding to the nutritional support for the patients with acute pancreatitis, it will vary according to the patient's severity, or the severity of the patient's condition. If the patient's with mild pancreatitis, there is no benefit from providing total parenteral nutrition. So the caloric intake will be by administering intravenous dextrose 5%, and after stabilization of the patient's condition and the removal of pain, or decreasing the pain and the removal of anorexia, you can start the enteral feeding, which mainly within 3 up to 7 days. Regarding the patients with severe moderate to severe pancreatitis, you have to provide nutritional support to overcome the hypercatabolic state of your patients, and also for stabilization of the fluid and hemodynamic stability parameters accomplished, and provide feeding via nasojejunal feeding with low-fat formula. That's why total parenteral nutrition will be required for the patients with severe pancreatitis, and should be of formula of fat emulsion to prevent the essential fatty acid deficiency. And you have to remember that the patients will be on total parenteral nutrition from hospital admission, not on enteral feeding, and the patients will be on NBO, or nothing per oral status, until the patient's hemodynamic stability will occur, because enteral feeding will stimulate more pancreatic enzyme secretion. So, lipid administration, high lipid administration will be avoided to prevent increasing triglyceride level, and which increase the inflammatory process development. Also, you have to provide the patients with frequent oral hygiene or oral care and the proper positioning of the patients during the enteral feeding to prevent aspiration. Provide the patients with the bed rest, which is prescribed to minimize and decrease the basal metabolic rate of the patients and to overcome the hypercatabolic state of your patients. Bed rest status will decrease the stimulation of pancreatic enzyme secretion. Also, begin the oral feeding once the abdominal pain subside and the patient's and the anorexia is stopped or resolved, and the patient's diet should be low fat and low protein to overcome the higher pancreatic enzyme secretions. Regarding to the intervention to rest the patient's pancreas, which include first insertion of nasogastric catheter for decompression of the stomach and remove the abdominal distension, and also decrease the stimulation of the pancreatic enzymes and nausea and vomiting and abdominal pain. A nasogastric tube in these patients with severe gastric distension or paralytic ileus is highly recommended. Keep your patients on nothing per oral status, as we mentioned before, until the abdominal pain subside and serum amylase and lipase return to the normal. And you have to remember that early oral intake can predispose to more abdominal pain and can induce further inflammation of the pancreas by stimulating the autodigestion process of the patients. Regarding to the other medical management, which include administration of histamine H2 blockers to prevent stress ulcer development, and starting aggressive respiratory care via initiating mechanical ventilation to provide respiratory support, then correcting the electrolyte imbalance, including hypokalemia and hyponatremia if hypokalemia if present, and then administer antibiotic for 2 weeks, then provide peritoneal lavage for decompression, and all precipitating factors such as alcohol and toxic medication should be eliminated, and finally insertion of biliary drainings for external drainage of biliary secretion. Regarding to the preventive measures for the patients with acute pancreatitis, first you have to identify the underlying cause or the causative factors for the development of this condition, then stop the etiological factors or this cause, and according to the cause, if the responsible factor for pancreatitis is gallstone or cholelithiasis, the patients will be benefit from undergoing cholecystectomy. If the cause is alcohol consumption, the patients should treat it for addiction. In relation to the surgical management of the patients with acute pancreatitis, pancreatic resection may be beneficial for the patients with necrotizing pancreatitis to prevent the development of systemic complications. Also, administration of broad-spectrum antibiotic, especially in the patients who require surgical debridement of the necrotic tissue. Cholecystectomy will be beneficial for the patients with the causative factor of pancreatitis of gallstone or cholelithiasis. And finally, endoscopic sphincterotomy which is an operation to cut the muscles between the common bile duct and the pancreatic duct. To sum up, there is a group of recommendations during caring for the patients with acute pancreatitis, which include offering a regular analgesia to promote patients' comfort, provide the patients with antiemetic to control nausea and vomiting, give the patients prescribed intravenous fluid and other supplement to correct the hypovolemic status, and keep the patients with additional dehydration, in addition to careful monitoring for intake and output to avoid the overhydration status. Also, accurate fluid balance is very essential. And finally, provide the patients with the oral care during the nothing per oral status, also with the continuous monitoring of the bowel sound to prevent the development of paralytic ileus, and be cautious for the measures during the nasogastric tube insertion to avoid aspiration, and provide the patients with psychological support and reassurance. Also administer the antibiotic, and consider the universal infection control measures to prevent the development of sepsis. And as we mentioned before, acute pancreatitis is one of the triggering factors for the development of systemic inflammatory response syndrome and SIRS. So provide the patients with the schedule of positioning or turning every 2 hours. Encourage the patients to perform deep breathing and coughing exercise for prevention of atelectasis, and provide the patients with the thromboembolism prevention bundle, including wearing elastic stocking, and provide active or passive range of motion exercise according to the patient's cooperation level, and administer low molecular heparin as prescribed. Also, you have to monitor the patient's vital signs at least hourly for early detection of any hemodynamic instability, and then monitor the patient's ECG and oxygen saturation, and finally provide the patients with core nursing care and regular hygiene. Furthermore, you have to monitor the patient's blood glucose level and administer insulin according to the hospital policy on the sliding scale, and then provide the patients with psychological support for pain and anxiety, and provide the patients with additional explanation and education before any intervention, and then monitor any signs for the development of local and systemic complication, and finally educate your patients before hospital discharge regarding the lifestyle modifications of continuing on a low-fat diet, and proper management for gallstone or cholestasis, and finally reduce or stop the alcohol intake. Regarding to the complications of acute pancreatitis, you have to remember that it's one of the triggering factors to the development of systemic inflammatory response syndrome, as well as multiple organ dysfunction syndrome. That's why the patients at risk to develop complications for each system. Regarding the immunological system, the patients at risk to develop decrease in neutrophils function and decrease in the immune response, and the bacterial translocation with aspiration of bacterial toxins. Regarding to the pulmonary system, the patients at risk to develop atelectasis and pneumonia, hypoxemia, pleural effusion, as well as adult respiratory distress syndrome. Regarding to the hematological and coagulation problem, as we mentioned before, inflammatory process also together with alteration in coagulation. That's why your patients at risk to develop disseminated intravascular coagulopathy. Regarding to the cardiovascular system, the patients at risk to develop hypovolemic shock from massive vomiting, cardiac dysrhythmia, as well as pericardial effusion and cardiac tamponade. Regarding to the renal system, the patients at risk to the development of acute tubular necrosis, oliguria, and electrolyte imbalance. And finally, locally, the pancreatic tissue damage will be increased and affect the patient's general hemodynamic status. Now we finish the lecture. And you have to remember that acute pancreatitis is considered as a life-threatening health problem for critically ill patients, and it is one of the triggering factors to the development of systemic inflammatory response syndrome, as well as multiple organ dysfunction syndrome. And so you have to perform Ranson severity prediction scale for your patients to identify the severity level of the patient's status. And finally, remember, prevention is recommended rather than cure. And thank you.